Good morning, good afternoon, and good evening to everyone joining us from wherever you are around the world. Distinguished guests, ladies and gentlemen, it is my great honor to welcome you all to this highly anticipated awareness seminar. Before we begin with our main presentation, allow me to provide a brief overview of the initiative that brings us together today. INSTAL Africa, Innovation, Science and Technology for Action and Learning in Africa, is the result of collaborative efforts initiated in October 2023. This initiative leverages the Drosophila melanogaster fly model and state-of-the-art infrastructure to enhance fundamental research capacity in Rwanda. Rwanda has made remarkable strides in advancing its scientific capabilities, recognizing the pivotal role of research in sustainable development and public health. INSTAL Africa was born from a collaboration between the Foresight Institute of Research and Translation Rwanda, or FIRAT Rwanda, and its technical partner, Drosophila UK, in conjunction with key national institutions such as the National Council for Science and Technology, Rwanda Biomedical Center, the National Industrial Research and Development Agency, the University of Rwanda, and the Rwanda Food and Drug Authority. This collaboration embarks on a 5-year comprehensive capacity development plan aimed at cultivating the next generation of scientists and fostering research excellence across medical, applied, and fundamental sciences. From healthcare innovation to agricultural production, this partnership envisions driving progress in public health and sustainable development across Rwanda and beyond. It is against this background that we convene today, united in our shared commitment to advancing science, technology, and public health for the benefit of our communities. With that foundation laid, it is now my distinct pleasure to introduce our invited guest speaker.
Dr. Musa Iyiola is a distinguished neuroscientist and an award-winning researcher whose work stands at the intersection of fundamental neuroscience and revolutionary psychiatric care. Currently a postdoctoral fellow at the University of Maryland School of Medicine within the Division of Biological Psychiatry Research, Dr. Ajibola is dedicated to unraveling the complex neural mechanisms that govern brain health and disease. His academic journey began with a foundation of excellence at the University of Ilorin in Nigeria, where he was recognized as the overall best graduating student in the Faculty of Basic Medical Sciences. This early success set the stage for a global career that led him to Taiwan, where he completed his PhD in interdisciplinary neuroscience through the prestigious Taiwan International Graduate Program at Academia Sinica and National Yang Ming Chiao Tung University. His doctoral research, which earned him the 2021 Doctoral Dissertation Award, provided groundbreaking insights into how hypothalamic glutamate and GABA co-transmission modulates hippocampal circuits to support long-term potentiation and memory. Dr. Ajibola's current research, conducted alongside world-renowned experts such as Professor Todd D. Gold, is at the forefront of biological psychiatry, specifically focusing on the synaptic basis of fast-acting antidepressants. By investigating how ketamine metabolites persistently prime synaptic plasticity, his work seeks to unlock new pharmacological pathways for treating major depressive disorders. His prolific output, including recent high-impact publications in premier journals such as Neuron and Neuropsychopharmacology, reflect a deep expertise in using electrophysiological and molecular techniques to bridge the gap between laboratory discovery and clinical application. Beyond his research at the bench, Dr. Ajibola has demonstrated a profound commitment to academic leadership and mentorship across the African continent and internationally. He has previously served as a program coordinator and assistant lecturer at Kampala International University in both Uganda and Tanzania, and currently holds an adjunct assistant professorship at Notre Dame of Maryland University. His leadership extends into the editorial and professional realm as the editor-in-chief of AROC in Pharmaceutical and Biotechnology, where he actively shapes the intellectual direction of emerging research. As a fellow of the National Institute of Professional Engineers and Scientists and the International Africa Society of Sciences, Dr. Ajibola is a recognized voice in the global scientific community. His recent accolades, such as the 2025 Dr. Pat McMahon Trainee Research Poster Award, further underscore his standing as a leader in his field. As the distinguished guest speaker for the 19th INSTAL Africa webinar, Dr. Ajibola will present on deciphering the synaptic basis of fast-acting antidepressants, sharing his unique perspectives on the challenges and opportunities in neuroscience today, and inspiring the next generation of African scientists to pursue breakthrough innovations in discovery science. Dr. Ajibola, the floor is yours.
Everyone around the world. And thank you for the introduction. And also, first of all, I would like to appreciate Professor Adedeji and INSTAL Africa for the invitation to share our research on antidepressants with everyone here. So today, as correctly introduced, that I'm going to be discussing and dissecting our work on antidepressants and how to unlock the next generation of fast-acting antidepressants. So first of all, I would like to disclose that there is no conflict of interest. So most of the work I'll be presenting today, they are funded by National Institute of Mental Health in the United States, and there is no industrial funding for most of the work we are going to be presenting today. So first of all, I would like to introduce major depressive disorder. What are the symptoms and what are the treatment challenges? The symptoms of depressive disorder include chronic emptiness, unyielding sadness, hopelessness, restlessness, fatigue, and no interest in what one's enjoyed before, and was begin to lose interest in those enjoyable activities. And depression have some side effects that affect the productivity of patients suffering from depression. One of them are absenteeism and presenteeism, like people not being able to go to work because they are depressed, or people going to work but they have low productivity at work. And also, depression also affects personal and social life disruption. It comes with the risk of suicide behavior, having some suicide ideation. Although there are current medications, there are current drugs for treatment of depression. However, these drugs comes with some they come with some challenges. First is most patients are not responsive to this drug. They have low remission rates. Another major problem with them is that they have delay onset of antidepressant effects, whereby patient may be waiting. When a patient takes a drug, they have to wait for like sometimes 3 to 4 weeks, and it can even extend to like 10 weeks sometimes, waiting for the drug to have effect so they can have a better mood and a stable mood. However, it may not come. So in addition to these, there are some patients that are resistant to the current antidepressant. About 30 to 40% of patients suffering from depression are not responsive to the current standard antidepressant we have in the market today, such as the selective serotonin reuptake inhibitors that are commonly available. Some patients are not responsive. These patients they are categorized as treatment-resistant patients. So, what do we do in our lab in order to contribute to science that can discover new treatments for this disease. Our lab is focused. We are focused on understanding the mechanism of the already available treatments, and then how can we leverage on the understanding of this treatment to develop better treatments for depression. So we are our overarching aim is to develop next generation of rapid acting antidepressants. That means depressants that when patient takes them today, in the next 1 hour, they can feel a change in mood, not like waiting for the next 3 weeks or 4 weeks. So to introduce some basic pathogenesis of major depressive disorder, literature have shown that the some of the bases or the causes of depression include first is a disruption or dysfunction of the hypothalamic pituitary axis. That means due to stress or disruption in the monoamine synapses or inflammatory responses, or it can even be a genetic being inherited, genetic being predisposed to depression as a result of genetic makeup. And also structural and functional remodeling in the brain can also cause this. Also, what is also common is a socio-ecological disruption. For example, a child that is being exposed to childhood abuse or stress or traumatic events that result into a long-lasting depression. And some of the strategies that has been proposed to prevent depression include having enough sleep improvement, dietary adjustment, social intervention, exercise. These are strategies that can help to improve depressive symptoms or prevent depression. So, how do we have improved treatments? So, the first thing for us to have improved treatment, we have to understand what is the challenge we have with the current available treatment. So, I will use this chart to show how patients develop depression and how depression actually what's the cause of depression. So when you look at the chart here, you can see that a patient in having a standard mood, regular mood, no sign of depression, in a state of a euthemic state, suddenly you see a drop in the mood, and then until the drop in the mood enter into depressive state, and then it's been sustained for a while, and then the patient was going to be diagnosed. When the state of being depressed is being sustained for a long time, then the patient is going to be diagnosed as being a major depressive patient or episode there. So when the patient takes the currently available antidepressants, we see that initial treatment with currently available antidepressants, this is the intake time, and then the onset of effect, I mean the return to euthemic stable mood, is going to be, there's going to be a lag for like sometimes 10 to 14 weeks before you can see improvement in the mood. And so these are the currently available standard antidepressants that we have here. But what we are interested in developing some new drugs that when you have initial treatment, there can be immediate onset of action. For example, when the patient receives the drug, they can have immediate improvement in their mood. So this what we call the next generation of antidepressants and also anti-suicidal ideation treatment. So what happened in these? What is most common is that whenever patients are waiting to see the effect of their medication they are taking, this time they start to have some idea of suicide. And this most of the time, some patients may resort taking their own life. So, so that means it's very key developing, understanding how this treatment works, so we can develop better treatment. So that means there is a need to identify the cellular and molecular targets, so we can develop new medications. So already is a non-competitive NMDA receptor inhibitor, and the formulation are available with different trade names, special K, vitamin K, and they are only available by prescription only, and they are also available they are only given to patients under their clinical settings. That means they are only administered in the hospital settings. Patient cannot go home with all these formulations. So they are the class of drugs. Ketamine is a dissociative anesthetic and is an hallucinogen. Medically, it's being used medically and it's being used for recreational purposes. In veterinary, is used as tranquilizers. In surgery, is used as anesthesia for surgical procedures, and recreational use as a psychedelic. And recently, ketamine was approved by FDA for the treatment of treatment-resistant depression and for major depression with suicide ideation. That means whenever a patient is already having some suicide ideation, the doctors are allowed to administer ketamine to this patient. Uh, so, uh, the availability of ketamine is IV 100% available, IM is 93%, and orally only 20%. So most of the time, patients are administered ketamine through IV, intravenous route of administration. So what's now the challenges with ketamine? Number one is that ketamine has some side effects. Number one is psychological. There is whenever a patient receive ketamine, they have decreased awareness of their environment, sedation, dreamlike state, vivid dream, distractibility, and generally uncommunicative. Uh, they also have a sign of a dissociation. Sometimes they feel pseudo hallucination, impaired thought process, out of body experience. Some patients will complain they are lifting, they see themselves in air, changes in perception about the body, surrounding time and sounds, they hear some sounds. So these are some of the side effects associated with this with ketamine, that is limiting its use to only the clinical setting, only in the hospital. So another physiological effect is that ketamine comes with tachycardia, increased blood pressure, insensitivity to pain, and sometimes can cause lesion in the brain. And also it can result into addiction. It can become habit forming, whereby the patient just want to take more, and resulting into drug craving. So, but ketamine has been shown to be effective, unlike the standard antidepressants available out there. When ketamine are given to patients, some patients, you can see if you compare this data published in 2006, you can see here, if we look at the placebo and the ketamine, here shows that the ketamine, immediately the ketamine is given, you can see a drop in the depression rating scale. That means depression symptoms dropped, and this drop happens within 60 minutes, within 40 minutes of administration, and this continues for the next 3 days. So that's very rapid. and very fast. So, and this continues for about 3 days, sometimes 7 days. So this kind of way is believed that ketamine has revolutionized the treatment of depression and understanding of how we can develop uh, fast-acting antidepressants. However, however, the problem still remains that ketamine can only be given in the clinical or hospital settings. So, question is that how does ketamine works? Can we understand how ketamine works? And then from there, if we can develop new treatments that we don't need to use ketamine again, that we can just understand how ketamine works. Then from there, we can develop uh, new drugs that we have ketamine-like effects, also fast acting, but without uh, side effect profile of ketamine. So to understand this, over the years, scientists all over the world have been spending time in funding to understand how ketamine works, how it brings about the fast acting antidepressants. So if you look at this panel, you can see that these are synapses in the this is in rodents, in mouse. So these are synapses of no stress. That means no stress, no depressive symptoms. However, when they are stressed, that means stressed and then having some depressive like symptoms, you can see that there is a shrinkage of the synapses. They are not only shrink, they become viewers. You see few synapses there. But when ketamine was administered, 21 days stress plus ketamine, 24 hours after the ketamine was administered, you can see there is a recovery of the synapses. They become wider, longer. So the same thing happens in human. So this is a control healthy human. If you look at the brain, these are the both signal showing synaptic vesicles, the synapses in the human brain here. And when the brain is when the person develop depression, major depression, you can see the both signal decreased in the depressive patient. But when the patient receive ketamine, 24 hours later, you can see the recovery of the both signal. So that shows that this is another evidence that ketamine is acting at the synaptic level. So if you want to understand ketamine, we should go to the level of the synapse to know how it's working and then understand how it's working and then develop new medication. So there are three major pharmacological classes with presumed rapid antidepressant effects. Agents that can target glutamatergic modulators, glutamatergic transmission, agent that can some drugs that are neurosteroid GABAergic modulators, and also some opioids, some serotonergic hallucinogens. These are some of the pharmacological agents that are presumed to have potential of having fast-acting antidepressant effects. One of them is ketamine, nitric oxide, that's the popular laughing gas. And so they have been proven to have, to have rapid-acting antidepressants. Also, nitric oxide has also been proven to have fast-acting antidepressant effects. Also, there are some GABAergic modulators as well. This, for example, bresanolone is known to be very effective in postpartum depression. And so, and also recently, the psychedelics are coming up, the serotonergic hallucinogens, the mushrooms, the wonder or magic mushrooms have also been proven to have some level of rapid acting antidepressant, especially the psilocybin. So So all these three agents, the interesting part of them is that they all converge at the synapse. When they bind to the receptors, they trigger receptor signalings that result into plasticity, synaptic plasticity, cascade of events. But this cascade of events converge, though they have different pathway, but they converge into into four major outcomes. First, there is that's reported that is a neurogenesis, new formation of new neurons, neurotrophins like BDNF are being released, new proteins are being formed, skeletal reconfiguration, and then formation of spines to improve the synaptic connectivities there. So that shows that the potential, the three major classes of pharmacological agents that have that have potential of being fast acting, they have they have a convergence. And the convergence is that they work on the synapses, they act on the synapses, trigger some uh, cascade of signaling pathway that promote plasticity, that promote synaptic strengthening. So, so what we are trying to understand now is that whenever ketamine is being administered, the pharmacokinetics is that within 30 minutes to 40 minutes, ketamine is out of the body. However, the effect of ketamine is still being sustained. So if you look at this chart, the racemic ketamine, whenever being administered, following the administration of racemic ketamine, is being metabolized in the liver into RS-norketamine, and then from RS-norketamine to RS-DHNK. So the norketamine is further being broken down, being metabolized into what we call the HNKs, hydroxy norketamines. So these hydroxy norketamines, they are about 12 of them that has been identified in the brain. However, the most abundant of them is the label here in green, which is the hydroxynorketamine, the HNK, is the most abundant of them. So the question is that is the effect since whenever ketamine is administered and after 40 minutes is out of the system, it's already metabolized and it forms all these new compounds. So one can think that maybe ketamine it's not even ketamine that is really performing the function of antidepressant effect. Maybe they are the metabolites of ketamine are the compounds that are performing the antidepressant effect that we are seeing. So we are and others we have been trying to look at how to understand ketamine better and why do we need to go actually dig into the metabolites of ketamine after being administered in the body. It forms a lot of metabolites. Can we understand these metabolites and then try to know or try to investigate whether these metabolites are enough to even exact the antidepressant effect without even using ketamine. Therefore, we are going to be able to avoid the side effects or limiting the use into the hospital settings. So one of the experiments that has been done in mice is to check the liability of ketamine. This is a kind of a self-administration experiment whereby the animals are presented with RS ketamine and also with one of the metabolites of RS ketamine, which is HNK. So you can see from this data that the ketamine administration, the animals are going back to press the lever and then to have more and more and more of ketamine. However, if you check the metabolites, so the metabolites is fairly comparably stable throughout the infusion process. So that shows that the animals, they are abusing the ketamine. They go back to press the lever so they can have the ketamine here. And also We have also shown that when ketamine is deuterated means an hydrogen in ketamine at C6 is being replaced by a deuterium such that it becomes stable, so it won't be metabolized. So if you don't have, if you have a ketamine that is not being metabolized, are we still going to see the antidepressant effect? So this is another experiment in mice where uh, one of the model to study the depression, which is a forced swimming test, and check the mobility of the animal. When you look at this data, you can see here that when the animal is being administered ketamine and is being also been administered deuterated ketamine, that means the ketamine that cannot be metabolized. You notice that in 1 hour, both the ketamine and deuterated ketamine, they all have shown antidepressant effect here. However, 24 hours later, only the ketamine that is not deuterated, the deuterated ketamine, this D2 ketamine, has lost the antidepressant effect. That shows that the long term, the sustained antidepressant effect of ketamine is majorly due to the metabolism of ketamine into its metabolites. So the question now comes that maybe ketamine antidepressant effect might actually come from its metabolites rather than the ketamine itself. So when you, in a clinical settings, whenever ketamine is being administered, uh, when the during the induction phase, when it's administered, immediately you see the pharmacokinetics, the ketamine rise in the bloodstream, in the plasma, and then you see it disappear within 30 minutes. And also the direct pharmacodynamics, that means the direct side effects like dissociation, hallucination, and other stuff, they also happens within short time, like within 30 minutes. However, if you look at the indirect pharmacodynamics, the symptoms relief, you can see that the symptoms relief is sustained for a while before the patient receives another injection, which also push the effect up more. So that shows that the ketamine itself driving the dissociation, the side effect is majorly is driving this dissociation or the side effect you are seeing, but it may not be responsible for the symptoms relief in patients. So we are proposing that the symptoms relief we are seeing is the symptoms relief we are seeing is majorly because of the metabolites. So how do we study these metabolites? As I mentioned earlier, during whenever ketamine is administered, immediately is being metabolized in the liver, and then we can have all these 12 compounds, which are the HNKs. We have the HNKs there. So the question is that these HNKs, could they be the major agents driving the antidepressant effect? And how do we test this? How do we test all of them? I'm sure, but over the years we have been focusing on one of them, which is the HNK, and it's obvious. The reason is because HNK is the most abundant in the brain compared to other HNK, and also since 2R6R HNK is stable compared to others. So in collaboration with the chemists, we in the National Institute of Mental Health, we have been able to synthesize all these 12 compounds that we are trying to run and try to see if they have antidepressant effect. So at the behavioral level, we have tested one of them, which is a 2R6R HNK. So the 2R6R HNK, as I showed the other time, that if you compare it with the ketamine, that's the parent compound, you can see that it's very stable. The animals are not abusing it. They are not going back to press the lever and get it. So that's a plus for this drug, that it has low abuse liability. In addition to that, question would be that does it has a rapid antidepressant effect of ketamine? Answer is yes. In 2016, our lab have shown that when you look at this data here, when you administer ketamine and you measure the learned helplessness, immediately administer ketamine, you can see a drastic reduction. So that shows that that's an indication of antidepressant effect. And when you look at the data for HNK, 2-hour 6-hour HNK here, as the concentration increases, you can see there is also a decrease in escape failure. So this shows that ketamine, this shows that HNK has antidepressant-like effects of ketamine without having the side effects of ketamine. So not only learned helplessness, but also in forced swimming test, that's another test in animals to check antidepressant like effects, and also Shuku preference test. You can see here that both ketamine and HNK decrease immobility time. And also in Shuku preference test, that this is a test to check when animals are supposed to prefer sucrose, but when animal is depressed, they don't have any preference between sucrose and water. So here you can see that the HNK also show high preference for sucrose. So the question now is that what are the brain areas to focus, because brain has many different parts of the brain. So this we take insight. We took insight from this paper that shows that whenever there is a depression, most of the brain area that is being affected mostly there is decreased activities in the hippocampus, in the dorsal hippocampus, and also hypothalamus here. So you can see here that this is a control animal here, around 88. But when there is an induction of depression, there is a decrease in the glucose metabolism, as you can see here. So, and also we have experience in recording activities of synapses in the brain. So one of the first set of experiments we did that we can do how do we check if these compounds are actually enhancing the synaptic activities? Because whenever there is a depression, one of the things you can see is that there is a decrease in most brain areas. Most brain areas show a decrease in synaptic transmission. So any drug that will show potential for as an agent of antidepressant agent, we have property of strengthening synaptic transmission. So what we did is that we perform the recording from mice, and then we washing on the brain of the mice. We washing this drug 2-hour 6-hour HNK. You can see from this data that immediately we washing the drug, you can see an increase in the synaptic transmission. However, this is not in all synapses. In some synapses, they are not responsive to this drug. So from here we can show that the 2-hour 6-hour HNK, which is a metabolite of ketamine, it has a synapse-specific potentiation effect. As you can see here, it only occurs at this synapse, but not in other synapses we are showing here. In addition to this, we also show that not only that this compound has ability of enhancing synaptic transmission, but it also can enhance long-term potentiation at hippocampal synapses. What does that mean is that when we say we have better learning, better memory, what's the molecular substrate for that is that you have better ability to have synaptic strengthening in response to activity or learning or environment there. So what we here we show that when we remove the brain of the uh, mouse here, and then we incubated the brain with HNK. You can see here that, and then performed recording with electrophysiological recording. So here you can see surely that the HNK increase the ability to form long-term potentiation here. So, and in addition to that, we have also shown that apart from these HNKs, other HNKs like the other HNKs we have shown, some of them like 2R6R, 2R6S, 2S6R, 2S6X, they are also showing that whenever we wash in the drug on the slices, you can see an immediate increase in the synaptic strength there. So this shows that these drugs they have potential of increasing synaptic strength. So all these experiments cannot be done in human. You can't take human being and try to wash in the drugs on the human brain. Then. So that's why the use of animals, rodents, to test all these drugs. Then before we move this drug forward to clinical trials to see or move them to behavior and see if they have antidepressant effect or try to do some clinical trials to see if they are agent of they are fast-acting antidepressants. So, so once we have shown that all these compounds they have ability, they have potential of becoming fast-acting antidepressants, given the timing we wash in our drugs and the time it takes for the synapse to get being strengthened. So, because in depressive patients, what we have is most synapses in the brain are depressed. So any agent we can bring in, either metabolize, either exercise, either or even herbs or anything that can strengthen the synaptic activities is a potential agent is a potential agent as fast acting antidepressants. So what we notice here is that the hierarchy of the metabolites, some of them are stronger than the other, as you can see in this bar graph. We also show that this enhanced synaptic strength is accompanied by a decrease in synaptic transmission, which is just showing that the mechanism of action here is likely to be a kind of a presynaptic mechanism of action. I think I will talk more about that in the during the question and answer. So now we have also shown that how do we manage depression? How do we enhance the effectiveness either of the available drug or the coming potential fast-acting antidepressants? So one of the hypotheses we come up with is that what we call the synaptic priming hypothesis. This priming hypothesis means that preparing the synapse, even when you have not administered the medication, when you have not taken the medication, can we prepare the synapse to such that we augment the effect of the drug? So we call it kind of the antidepressant itself. We call it pharmacological primers themselves. Rather, antibiotics themselves are pharmacological primers. Why the contexts at which you are administering the antidepressant are called contextual primer. So, for example, when someone is taking antidepressants, it depends on the environment of the person. Also, maybe the person has been someone that do regular exercise, or maybe the person has experienced some kind of acute stress before taking the, or during or before taking the antidepressant. So all these things are, we believe that when a synapse is, if you have, we categorize synapses into two: unprimed synapse and primed synapse. When you have unprimed synapse and you take an antidepressant, the effect is not, it may not be as much as when you have a primed synapse. When you have a primed synapse, and then you administer the medication, you can have an enhanced activities of the drug. For example, if you look at this image, for example, if you have a kind of social psychotherapy, a social support before the administration of the drug. For example, when the patient comes to the clinic, the patient sees a psychologist or a psychotherapist, and then talk to the patient before the patient receive the medication. This can enhance the effect of the drug as well. So we call this hypothesis a kind of a synaptic priming hypothesis of depression pharmacology. Uh, so now what we are doing majorly in the lab now is that we are currently looking at all these, the bioactive metabolites of ketamine, and try to investigate them to see if they have potential, or if they have ability of being strengthening strengthening the synapse and making the synapse awake again after depression. So one of them, we have quite been successful so far, because one of them that is majorly abundant in the brain, shown here in green, the 2-hour CSRHNK, is currently, it has already been passed the phase 1 clinical trial, no toxicity, and currently in phase 2 clinical trial for pain, depression, and PTSD. So summary, the take-home message here is that number one, ketamine produces rapid antidepressant effects even in treatment-resistant depression, and metabolism of RS ketamine to 2-acetylcholine is essential for its antidepressant effects. Also, 2-acetylcholine demonstrate ketamine-like antidepressant action without ketamine side effects. So that's the major thing, that this metabolite of ketamine, it has ketamine-like antidepressant actions effect without the side effect of ketamine. And I mentioned the other time that this drug is currently in its phase 2 clinical trial. And also, other metabolites of ketamine, we are also looking at them and see how, if they have the ability of strengthening the synapse, and if they have antidepressant effects, especially if they can behave as fast-acting antidepressant effects. So most of this work they were done in Todd Good Lab, University of Maryland, and I appreciate all the lab members of Good Lab, the NIMH, University of Maryland, and everyone that has contributed to this, to most of the work I've presented today. So thank you everyone for your attention.
Thank you. Thank you very much, Dr. Musa Iyiola. I think the floor is open now for questions from audience. I think you can see the question, Dr. Musa.
Oh, yes. Could you please elucidate the differences in the mechanism of action between fast-acting antidepressant and traditional ones? Oh, okay. So the traditional ones, that means the SSRI, what we know, what has been shown is that what they do is to uh, prevent reuptake of serotonin, dopamine, and so that these neurotransmitters can stay in the synaptic clefts and bind to the postsynaptic receptor and then strengthen the synapse. So that means they are also, the goal is to strengthen the synapse. However, for fast-acting antidepressants, the mechanism is, for now, which is the only one approved that is known, is ketamine. The mechanism is that ketamine is an NMDA receptor inhibitor, so it's going to block the NMDA receptor on the GABAergic neurons, interneurons. So these interneurons, they are inhibitory. So it blocks the inhibitory neurons and therefore reduce inhibition at the synapses and then enhance the synaptic activity at the synapses. So they are using different mechanisms, but the outcome, the convergence, is that they are strengthening synaptic activity. Thank you for the question. Are the metabolites of ketamine tested individually to establish their antidepressant activities? Yes, we have we have done one of them. We are convinced about one of them, which I mentioned that which is a 2-hour, 6-hour HNK. Currently already passed the phase 1 clinical trial. Currently in phase 2 for depression. But for others, we are testing them on slices, on brain slices from mice, to see if they have but not all of them. Sure, not all of them, from the data we have now, not all of them has ability of strengthening the synapses. But there are a few candidates, of some of them are candidates. But we are only sure of a 2 hour, 6 hour for now. Yeah. Thank you. More hydrophilic, okay, causing the rapid elimination from the body. Destruction should increase. It's likely due to, yes, it's due to P45 activities in the liver. Yeah. Thank you. Thank you for that contribution. Would you happen to know if 54 involved are established? Uh, uh, I am not very sure of this, but I know that majorly there are P54s that are involved in the metabolism of ketamine. Yeah. Dr. Deyama, is that all the questions? Do we have more questions? Okay. Oh, okay. Thank you.
Okay, I think the questions are over. But please, Dr. Musa, I will just ask that since we know that ketamine are currently being used,
Yeah.
or considering the side effect that you have mentioned, how are they now being managed? I mean, the side effect of this
Okay. So
ketamine.
thank you so much. If you check one of the charts I showed during the presentation, the side effect is it's it happens. Those side effects, so one of them is dissociation. Actually, dissociation happens when the patients are still in the clinic. Immediately they are administered. So, and it happens within, I think, dissociation most of the time within 30 minutes to 40 minutes. So those are the time that ketamine is still in the bloodstream. But after, because due to the pharmacokinetics of ketamine, it's going to be metabolized and out of the blood, out of the body within 30 minutes. So, so that's why the use is still being restricted to the clinical settings. So to manage this side effect, so the patient can recover from this side effect within the clinical settings. You understand? So that's why we need to get new drugs. Actually, we need to get some new drugs because we should have fast acting antidepressant that people can take home and use. But no, currently there is none. I remember that last year, uh, psilocybin, one of the psychedelics, almost passed the FDA approval. However, because of the experimental design deficiency, because during the experimental design, during the clinical trial, they combine psychedelic, the psilocybin, with social support. So it was difficult to actually differentiate between the effect of social support or the effect of the drug. So, but I know that there are some new drugs that are coming up that may not have the profile, the side effect profile of ketamine.
Thank you very much. I think in the absence of other questions, uh, allow me to use this opportunity to extend our gratitude to you for finding time to grace this occasion. Dr. Musa Ajibola, it's unfortunate that I did not meet you at KIU. I came
Oh,
shortly after you left.
oh, okay.
Um,
Nice to meet you here.
yeah, it's really unfortunate for me. But I must say that you've really done a lot, and that we have learned a lot from your wealth of knowledge. I
Thank you so
hope that
much.
when next we call upon you to share with us from your experience, what you've been doing in the lab for a long time, I hope that you openly accept our invite to also
Sure,
grace occasion
sure.
whenever we call upon you. Thank you
Thank you.
very much for your time. And
Thank you so
also
much.
to the audience, the yes, sir. And also to the organizers, I must say kudos to you for putting everything together, the backroom staff, and then the the organizers, the coordinator of Install Africa. Kudos to you for just keep doing what you are doing. Um, uh, from this end, we are saying thank you very much, and also to the audience. Without the audience, there is no lecture, there is no public science discussion. So, and I hope that whatever we have learned from here, we'll all take it to our different scientific community, and encourage people, or you take the message back to our different communities. Thank you very much. I hope that we see you next on our program. So I say, see you when we see you. Thank you very much.
Thank you so much. Nice to meet you.
So I think we have come to the end of the program. Till we see again, thank you very much.